Today we will be giving you an overview of audiology presented by Group 3, which includes Lindsay, Lauren, Annabelle, and myself, Cece.
Hello everyone, my name is Lindsay and I will be giving you a general overview about the profession of audiology, such as what it takes to become an audiologist, what they do, who they serve, and why this profession is important. So to begin, what does it take to become an audiologist? Currently, one must have a doctor of audiology, a doctor of philosophy, or a doctor in science in the hearing and balance sciences. And a state license is also required. One can obtain a state license by completing a prescribed course of study, completing 2,000 hours of clinical practicum, as well as passing a national examination in audiology. What do audiologists do? According to the American Academy of Audiology, the duties of audiologists include evaluating, diagnosing, treating, and managing hearing loss, as well as balance disorders in both adults and children. They prescribe, fit, and dispense amplification technology, such as hearing aids. And they also design and implement hearing programs, such as infant screening, which occurs at birth, and programs for hearing conservation. They also provide hearing rehabilitation training, and these programs can teach people how to speech read and listen effectively. Who do audiologists serve? Audiologists serve all ages, from infants to the elderly. Audiologists begin seeing patients as soon as they are born with those infant screening tests, as I mentioned in the previous slide. They can also see patients throughout their lifespan. For instance, when children have otitis media, which is a common disorder of the middle ear, an audiologist would be the one to diagnose and treat this disorder. The elderly can also see audiologists as hearing becomes more of a challenge and the assistance of amplification devices is necessary. I'm sure every one of us knows at least a few elderly people who require the use of a hearing aid. What are the different venues audiologists can be found? Well, audiologists are most commonly found in the medical field. According to ASHA, 73.5% of audiologists work in the healthcare setting. Of this 73.5%, 47.3% work in a non-residential healthcare facility, 25.1% work in hospitals, and 1.1% work in a residential healthcare facility. Audiologists in the medical field focus on assessments to find a cause of a hearing or a balance disorder. Audiologists can often be found in private and group practice. According to ASHA, 28.6 are employed either full or part-time, and these practices can be medical offices which focus on the ear, the nose, and even the throat. Some other venues an audiologist can be found working is in the educational field. This can be schools and the college level. According to ASHA, 8.4% of audiologists work in the K through 12 grade level, and audiologists working in these schools identify children with a hearing loss, and they also counsel and guidance about the hearing loss. According to ASHA, 7.2% work at the college level as a professor, a researcher, or a clinical supervisor. Audiologists can also work in the pediatric field, such as in pediatric hospitals, rehabilitation centers, and community-based centers, and they prepare parents for all rehabilitative challenges which may occur with their child who has a hearing loss. And audiologists can also work in the industrial field, and in this field they will work in industrial settings and can be found working with attorneys, industrial physicians, industrial hygienists, and safety engineers. Now, how does audiology contribute to our society? Well, early detection of a hearing loss at birth can be beneficial for both the patient and their family, as they can begin to cope and treat the issue before any further complications can occur. And audiology gives the gift of hearing. Without those amplification devices, it would obviously be very difficult to hear, and we would have to rely on some other source to communicate. And philanthropic work is also very important. The Hearing Charities of America, and there's also the Not for Profit Coalition for Global Hearing Health. Not only in our society, but these charities go abroad and work even in Africa with the less fortunate who don't have access to the healthcare like we have. Um, so, thank you so much. And now Cece is going to take us through the definitions of sound. Thank you.
Great. Thank you, Lindsay. We can begin by defining sound as a form of acoustic energy caused by a disturbance of molecules within a given medium. This medium is typically air. As the molecules are distributed, they bounce off of neighboring air molecules. Due to the elastic nature of these molecules, this creates areas of compression, as seen here in this illustration, where the molecules are more densely packed. As the molecules are compressed and spread, they travel in a wave formation. This waveform is specifically a sinusoidal wave shape. The upward part of this curve represents where the molecules are being compressed. The way our ears perceive acoustic input is not always synonymous to the actual sound because of differences in the physical makeup and acoustic properties of a person's ear. This is why it's important for audiologists to understand how to measure sound in order to accurately compare it with perceived sounds. There are two lenses to examine sound. Sound can be defined in an objective or a physical sense, such as ascribing various characteristics to measure sound like frequency, intensity, phase, and spectrum. These are all objective measures, which are absolute. These objective measures are very useful for analyzing sound waves. Specifically, frequency measures the rate of sound as it moves over time and space. This is also known as the number of cycles of a sine wave that are completed per second. The unit that's used to measure frequency is hertz, abbreviated as Hz. The lowest frequency a human can detect is 20 hertz, and the highest frequency a human can detect is 20,000 hertz. Intensity, on the other hand, measures the amount of sound energy, quantified as pressure, per unit of area, and it is computed using decibels, abbreviated as dB. The softest sound a human can hear is right at 0 decibels, and the most intense sound a human can hear is at 120 decibels before it becomes physically painful for the ear. Phase and spectrum are two other objective measures used to analyze sound waves. Conversely, sound can be thought of more subjectively as a psychological experience, such as through pitch, loudness, or the interaction of these acoustic signals. Psychologically, the acoustic experience of hearing is what we hear. There is a direct correlation between frequency and pitch, and the loudness directly correlates with intensity. Because people may be comfortable with varying levels of pitch and loudness, these are more perceptual components of sound. The interactions of acoustic signals can be either masked or localized subjectively. There are two main sound perception mechanisms: air conduction and bone conduction. With air conduction, acoustic energy passes from the outer ear to the middle ear and then to the inner ear. Once it reaches the cochlea in the inner ear, it's converted into an electrical signal that's transmitted via the auditory nerve to the brain. Bone conduction, however, bypasses the outer and the middle ear and passes straight to the inner ear, where it's converted into a signal and relayed to the brain. In normal hearing, sound is perceived louder through air conduction than bone conduction. Emittance and audiometric tests can be used to assess hearing. There are three main types of emittance tests. Static acoustic compliance assesses the mobility of the tympanic membrane in response to different values of air pressure presented to the external auditory canal. Tympanograms measure the change in middle ear pressure in relation to positive and negative ear pressures presented to the external ear canal. Acoustic reflexes assesses the ability of the middle ear canal muscles to tighten and stiffen in response to an intense sound. Audiometric tests can also be done, such as pure tone audiometry. Pure tone audiometry can be done with either tuning forks or audiometers. Tuning forks are designed to vibrate at a single frequency. They are used in a variety of hearing tests, such as the Schwab test, which looks at bone conduction in comparison to a patient's hearing in relation to the examiner's. This can lead to false results if the examiner does not have perfect hearing. The Rhine test uses the tuning fork as it's placed around the head in comparison to bone conduction against the air conduction. When using the Weber test, an examiner can place a tuning fork in a variety of places and proceed to ask the patient in which ear the sound is the loudest. Pure tone audiometry tests can also be done using an audiometer. The procedure for AC and BC tests are very similar. Both present a tone at a given frequency to the patient at least 5 times for at least 2 seconds per tone. Usually the down 10, up 5, or Hewson-Westlake method is employed as a standard way to determine the threshold. With air conduction, ear receivers are inserted into the ear and deliver the sound through the outer ear to the tympanic membrane. The bone conduction test completely bypasses the outer and middle ear to determine how well the inner ear is functioning. To administer bone conduction tests, an audiologist uses a bone oscillator, a device that vibrates at given frequencies and is placed on the mastoid bone, which is located directly behind the ear. Often, BC is thought of to be more challenging due to the incidence of cross-hearing. Cross-hearing is a phenomenon in which the bone oscillator is placed on one ear, yet both ears may be stimulated. Bone conduction is complex in that there are 3 ways in which the inner ear can hear the tone: through inertial bone conduction, compressional, and osteotympanic bone conduction. It's also important to note that bone conduction tests is almost always following an air conduction test. After pure tone audiometric tests are done, they can be plotted on an audiogram. Audiograms can reveal the degree of hearing loss from mild, moderate, severe to profound, as well as the different type of hearing losses, including sensory, neural, conductive, and mixed. Normal hearing individuals will have an air bone gap no greater than 5 to 10 decibels above 20 decibels hearing level. A sensory neural hearing loss will have an air bone gap of around 5 to 10 decibels that is below 20 decibels hearing level. A conductive hearing loss is found when bone conduction thresholds are better than air conduction thresholds, with an air bone gap greater than or equal to 15 decibels. A mixed hearing loss has air conduction thresholds and bone conduction thresholds that are both below 20 decibels hearing level, with an air bone gap greater than or equal to 15 decibels. While pure tone audiograms can provide a general idea of a patient's ability to hear certain sounds, it doesn't provide us with a degree of their sensitivity to speech communication. These understandings of sound have their limitations, as sound is rarely experienced in its simplest form as a pure tone, which is represented graphically by a sine wave shape. More often in nature, sound is experienced in complex forms, containing energy at a number of differing frequencies, amplitudes, and phases. This type of sound can no longer be understood by a basic sound sine graph, but must be broken down into its components by means of Fourier analysis. Fourier analysis breaks down complex waves into simple sinusoidal components through a mathematical analysis. The goal of speech audiometry is to determine the speech threshold at which a person is able to recognize and discriminate speech. Speech audiometry also measures a person's most and least comfortable loudness levels, as well as their ability to recognize words. There are 6 types of speech audiometry tests that can be performed. The first 5 are measured in decibels, while the last is measured as a percentage. SDT is a test used to find hearing levels of speech awareness by presenting cold running speech or conversational speech. SRT assesses the hearing levels for speech recognition through the presentation of spondaic words. The patient must reproduce these words correctly at least 50% of the time. MCL, UCL, and DR are all tested through the presentation of cold running speech. The MCL determines the most comfortable level of speech, the UCL determines the most uncomfortable level of speech, and the DR is the difference between a person's SRT and UCL. A normal DR is between 0 to 120 decibels, and a patient with sensorineural hearing loss would have a reduced DR. Lastly, WRS is determined by delivering speech above threshold or suprathreshold, which is usually 45 decibels or above threshold. Unlike the previous test, this test is scored as a percentage of the number of phonemically balanced words that are recognized. When conducting hearing assessments, it is important to try to do them in a controlled environment to minimize background noise effects that may raise auditory thresholds, resulting in false failed tests. Sound booths or chambers are useful because they have a more controlled environment. Sound level meters, which consist of microphone, amplifier, attenuator, and a meter, can be used to measure the level of background noise. Additionally, insert headphones further reduce background noise. Now Annabelle is going to discuss the general structures of the ear and how they work together to perceive sound.
Hello, my name is Annabelle, and I'm going to be walking you through the general structures of the human ear and how this entire system works to provide us with optimal hearing abilities. So here we have the human ear, which is composed of the outer ear, the middle ear, and the inner ear. The outer ear is responsible for the acoustic conduction of sound, the middle ear for the mechanical conduction, and then the inner ear for the transduction of mechanical signals into electrical nerve impulses that are interpreted by the brain. Let's start with the outer ear. The outer ear is formed by the auricle or the pinna, the external auditory nerve, and the tympanic membrane. The auricle can vary in size and shape, and its structure allows for efficient travel of high-frequency sounds. The primary function of the auricle is to localize and gather sounds that come from the environment. The main function of the concha is to localize and funnel sounds into the external auditory canal. Here you can see the external auditory canal. This structure extends inwardly in an upward position for adults from the concha into the tympanic membrane. It serves as a resonator, with best resonating ranges being between 1,000 to 5,000 hertz. It also protects the tympanic membrane from things such as trauma, and it maintains a constant temperature and humidity level. The shape is very important because it allows for essential functions such as the proper drainage of fluids, the blockage of unwanted objects, and normal secretion and release of cerumen. Here you can see the tympanic membrane, which is located at the end of the external auditory canal. The tympanic annulus is a ring of tissue that holds the tympanic membrane in place. The tympanic membrane is very concave and it is very thin. It's composed of 3 different fibers. In the fibrous portion of the tympanic membrane is the manubrium of malleus and the umbel. The umbel is at the center of the tympanic membrane and the malleus is attached to it. The greater area of the tympanic membrane is called the pars tensa because it makes the tympanic membrane more tense. The top of the tympanic membrane is looser and it is called the pars flaccida. Following the tympanic membrane, you find the middle ear, which its function is to carry vibrations of the outer ear to the inner ear and overcoming this loss of energy of sounds from air to fluid. The middle ear consists of the middle ear cavity, the eustachian tube, and the ossicular chain. Here you have the middle ear cavity, which is also known as a 6-sided box. It is an air-filled space, and it is composed of the epitympanic recess and tegmental roof, the tympanic plate, the membranous portion of the tympanic membrane, the labyrinthine process, the carotid process, and the mastoid process. The eustachian tube is located within the tympanic plate, and the functionality of the eustachian tube is very important. It's essential for maintaining middle ear health. It acts as a ventilator and a drain, keeping the middle ear dry and free of excess mucus. By the opening and closing of this eustachian tube, atmospheric pressure is maintained equally relative to the external auditory canal. Here you have the ossicular chain, which is comprised of the malleus, the incus, and the stapes. These 3 bones are tightly coupled to one another, and the vibrations of sound travel through the tympanic membrane along the ossicular chain and into the oval window. The middle ear can mechanically increase acoustic gain to offset the high impedance of fluid into the inner ear in three ways. These three primary modes of transfer are the area ratio, the lever action, and the shape of the tympanic membrane. So first, the tympanic membrane is 20 times larger than the oval window, and this results in a greater amount of force, resulting in a 20 to 25 decibel gain. The shape and size of the ossicles also provide an extra boost due to the malleus being longer than the incus, allowing for a lever action gain of 3 decibels. And then the cone shape of the tympanic membrane and the different thickness of it allows for the membrane to absorb the sound energy and create a buckling type of effect, allowing for a 2 decibel gain. So here you see the inner ear, which following the head of the stapes, you will find the oval window, and following this oval window, you can see the vestibule, which contains the vestibular mechanism and the auditory mechanism of the inner ear. The vestibule contains the organs of equilibrium, and this vestibule communicates with the auditory mechanism, which is the cochlea. The cochlea is this shell-like organ that is composed of the scala vestibuli, the scala tympani, and the scala media, and it is here that mechanical conduction gets transmitted into or formed into an electrical conduction. Here you can see the cochlea. It's a diagram of the cochlea unrolled, showing the three different structures that I just talked about: the scala vestibuli, the scala tympani, and the scala media, and other structures such as the basilar membrane and Reisner's membrane, and the organ of Corti. Within the basilar membrane, you can find the organ of Corti. The basilar membrane has 3 to 5 parallel rows of outer hair cells and 1 row of inner hair cells. It is organized synaptopically with higher frequencies encoded at the base of the cochlea. Each hair cell has stereocilia that you can see on this diagram embedded in the tectorial membrane, and sound is introduced to the inner ear by the movement of the stapes, which then sets a chain of reactions beginning with the oval window, and as the sound travels through the different portions of the cochlea, Reisner's membrane and the basilar membrane respond by yielding, which it causes the round window to be displaced. As all of this movement of membranes and fluid is happening, the basilar membrane is the one that's most affected as hair cells begin to twist and communicate with the auditory nerve endings, causing the signal to travel to the auditory nerve. The movement of the hair cells is also facilitated to some extent or to some degree as a result of the movement in opposite direction of the basilar membrane and the tectorial membrane. Outer hair cells are responsible for frequency discrimination and aiding the inner hair cells in enhancing the sound. The size of the electrical response of the cochlea is related to the extent of the twisting or the shearing of the hair cell. So following the process that happens in the inner ear, we have the travel of sound to the auditory nerve and the central auditory pathway as it travels to the brain as a neural impulse. The central auditory pathway begins as the auditory nerve receives a signal from the cochlea and then begins to move through the brain. The signal is transferred through the cochlear nucleus, the superior olivary complex, and the lateral lemniscus, which are all portions of the medulla region of the brain. Then the signal travels through the inferior colliculus, found in the midbrain, to the medial geniculate body, found in the thalamus. And it is at this point that the neural impulse that was once a sound wave reaches the auditory cortex. The temporal portion of the auditory cortex is responsible for the reading of sound frequency. The insular portion is responsible for the timing of the response, and the parietal portion associates sound with other past experiences, and the frontal portion aids in the memory of past sounds that we may have experienced. So here we have a diagram of the auditory nerve, which I mentioned in the previous slide. I'm just going to go into more detail about the electrical conduction and the different structures in this process. So here we have the internal auditory meatus, and it contains the eighth cranial nerve, which is composed of the vestibular portion, the cochlear portion, and the facial nerve. So the vestibular portion is made of the superior and inferior branch, and the fibers are innervated by the utricle, the saccule, and the semicircular canals. The vestibular portion carries balance information traveling from the inner ear into the brainstem. The third branch that you see is the auditory nerve, and this innervates the cochlea directly. Then the fourth branch you see here is the facial nerve. I'm going to focus more on the auditory branch of the eighth cranial nerve, and here you can see that it is organized tonotopically, with the outer edge of the nerve responsible for transmitting high-frequency information, the next layer being responsible for mid-frequency, and then the most inner layer of fibers responsible for transmitting low-frequency information. Hair cells located more apical on the basilar membrane encode lower frequencies, and the hair cells located toward the base of the basilar membrane encode higher frequencies. These fibers are all coiled, and their physical structure can be compared to something like twisted electrical cables. For every one hair cell, there are approximately 20 nerve fibers that can synapse with a hair cell. This auditory nerve attaches to the brainstem at the junction between the cerebellum, the medulla oblongata, and the pons. I'm going to explain a little bit further how this acoustic energy from sound input is translated into a mechanical energy, which it's ultimately generating an action potential in the form of electrical energy. The region where the sound wave becomes a neural impulse and creates action potential is known as the inner hair cell spinal ganglia synapse, and what basically happens is that when sound reaches the inner ear, the sound wave causes the basilar membrane to move upward, causing the stereocilia of the hair cell to deflect in a certain way, and as they are pushed against the tectorial membrane. This deflection causes the stereocilia of the hair cells to bend towards the longest stereocilia, and this opens certain mechanical protein channels, resulting in the excitation of the hair cells. This excitation then causes the release of glutamate from synaptic vesicles into the synaptic cleft between the cell body of the hair cell and the auditory nerve fibers. There are glutamate receptors on the auditory nerve fibers that bind to glutamate and open, and this causes an influx of positive ions that result in the depolarization of the membrane and the generation of an action potential. This mechanism is made further efficient by the structure that you see here in the middle, the synaptic ribbon. This structure sits at the base of the hair cell, and it tethers several filled synaptic vesicles to itself so that in the event of a hair cell excitation, larger amounts of neurotransmitter are ready to be released into the synaptic cleft and trigger action potentials. So following this process, you have the superior olivary complex, which receives the information from both sides, the ipsilateral and the contralateral cochlear nuclei. Then the structure is able to determine the sense of the direction of sound based on the timing or the intensity of the sound wave. The auditory pathway is responsible for this transmission of impulses from the ipsilateral lower brainstem, and the inferior colliculus is stimulated from the superior olivary complexes on both sides of the auditory pathways. The medial geniculate body is then connected to the inferior colliculus through neurons. And this medial geniculate body is located in the thalamus, which is the last station for the auditory impulses. So now Lauren is going to walk you through some disorders and treatment.
There are two categories of hearing loss, conductive and sensory neural. The picture on the left shows that conductive hearing loss is affected by the structures of the outer or middle ear. If there is disease or impairment in those structures, it will cause a conductive hearing loss. Sensory neural hearing loss is caused by disease or impairment to the inner ear structures. Now, if you look to the right, you can see two audiograms, one displaying a conductive hearing loss and one displaying a sensory neural hearing loss. For the conductive hearing loss, you're going to see an audiogram with high bone conduction scores. The part of the ear being tested for bone conduction is the inner ear, so those scores will be high, while the scores for air conduction, which tests the outer and middle ear function, will be low. Sensory neural hearing loss has an audiogram where the air conduction and bone conduction scores are just about equal, and both are low as you increase on frequency and lower the decibels. Before diving into all of the different disorders and impairments that can occur in the auditory system, I'm going to give a quick review on the different structures of the ear, starting with the external and outer ear. For the external ear, I have highlighted the pinna as well as the concha. The pinna gathers and funnels the sound waves entering our ear, and the concha is a bowl-like shape that helps localize the location of the sound or help our ear pick up where exactly the sound is coming from. The outer ear is composed mainly of the external auditory canal, or the EAC, and the tympanic membrane, informally known as the eardrum. Now, the tympanic membrane is a cone shape, and when the pinna funnels sound into the external auditory canal, it hits against that tympanic membrane, causing a vibration. Any disorders dealing with the external and outer ear mostly are affecting the function of the external auditory canal or the tympanic membrane. We will begin by looking at the disorders of the outer ear, starting with the external ear, or what you're able to see. So the first main disorder of the external ear is atresia, in which there's no visible opening to the auditory canal and no tragus. And this is a developmental pathology, meaning that it occurs in utero. Now, stenosis is a narrowing of that ear canal. It is not completely closed off, but as you can see from this picture to the right, it is a lot smaller than what you would see in a normal ear. For both of these disorders, the treatment is typically surgical. As far as the outer ear is concerned, one very common disorder is external otitis, or swimmer's ear, and this occurs when the fluid does not drain properly. And it breeds bacteria. And if you look at the picture here to the right, you can see the inflamed and red area of the external auditory canal. The treatment for this is antibiotics. Another outer ear disorder is excessive cerumen or wax buildup. And a third disorder I'd like to mention, which is extremely severe, is the perforated tympanic membrane, which causes changes in mobility and resonance, which means that the tympanic membrane can be affected in the way that it moves, how fast it moves, if it can vibrate at all when those sound waves hit. It can cause different degrees of hearing loss depending on the size of the hole, and the treatment can either be surgical or the tympanic membrane can naturally heal itself, leaving scar tissue in that hole's place. Now, as we enter further into the ear, I will provide a quick review of the main middle ear structures. We have the ossicular chain, which is composed of the malleus, incus, and the stapes, which are 3 bones, and the malleus is attached to the tympanic membrane, and following the malleus is the incus and then the stapes. So when a sound vibrates off of the tympanic membrane, it causes a chain reaction along the ossicular chain. Another portion of the middle ear that I've highlighted is the eustachian tube, and many of our middle ear pathologies that we see have to do with a dysfunction of the eustachian tube. The picture on the right just shows a close-up of the ossicular chain and exactly how it's connected to the tympanic membrane. There are a number of disorders involving the middle ear. One fairly common disorder is known as otitis media, or a middle ear infection, and this is caused by a eustachian tube dysfunction. So the eustachian tube is not draining as it should, and fluid is backing up into that middle ear cavity, as you can see in the picture on the right, and it becomes infected. The treatment for this is typically antibiotics. However, if the middle ear infections are chronic in the patient, a shunt can be placed to help that eustachian tube drain the fluid properly. Suppurative otitis media is a middle ear infection including blood, and you can see in the picture the blood pressing against that tympanic membrane. The treatment for that is antibiotics as well. Disarticulation of the ossicular chain is less common because it occurs normally due to head trauma. And when there is that head trauma, the incus malleus and stapes bones can disconnect, and the treatment for this is surgical repair. Serous effusion is a buildup of non-infected fluid. You can see the picture here to the right. The tympanic membrane looks swollen, and you can see the clear fluid build up against that tympanic membrane. The treatment for this, because of its non-infected quality, is decongestants. Finally, otosclerosis is a growth of spongy bone around the stapes, affecting the movement of the stapes. And if you look at the picture here on the right, you can see exactly where that spongy bone begins to grow there around the stapes and how this could affect the transmission of the sound wave into the inner ear. The main structures of the inner ear are composed of the vestibule and the cochlea. The vestibule contains the organs of equilibrium, and that part of the inner ear is innervated by the vestibular nerve. And the cochlea contains the most crucial components for proper hearing, and that part is innervated by the cochlear nerve. Both the vestibular nerve and the cochlear nerve are a portion or a branch of the auditory nerve. The oval window acts as the entryway into the inner ear, and the stapes is what connects to that oval window and begins the transmission of that sound wave into the inner ear. Several disorders of the inner ear include ototoxicity, and the causes for this can be a number of very strong medications, and these medications travel through the bloodstream, and the outer hair cells within our inner ear are very metabolic and require a lot of blood. So because of this, these medications traveling through the blood affect those outer hair cells and can destroy them. Now, the treatment for this is tricky in itself because the body uses natural antioxidants to combat this ototoxicity. But within the outer hair cells, there is a very limited amount of those antioxidants. Meniere's disease is caused when the membranous portions of the inner ear fill or overfill with endolymph. And if you look at the picture on the right, you can see the different canals here of the inner ear just bulging with that endolymph. And this can cause vertigo, tinnitus, and feeling of aural fullness or pressure, and a sensory neural hearing loss. And you can see in the picture what this swelling does. It distorts the sound information, it distorts what travels to the brain. That's why it can cause that sensory neural hearing loss. The treatment is typically a shunt to help drain that fluid consistently. Presbycusis is age-related hearing loss, and if you look at the audiogram down at the bottom of the screen here, you can see that as we age, our scores, as our frequencies go up and the decibels go down, our scores decline with age. This is due to a change in vein and capillary function. The oxygen levels in our blood can lower, causing harm to the structures of our inner ear. Now, the treatment for this is amplification or hearing aids, which I'll discuss in a few slides. Noise-induced hearing loss can occur with one sudden loud noise, or it can occur over many years of being exposed to loud noises. If you look at the chart here, you can see that at certain decibels, there's an exposure limit or an amount of time that you can be exposed to that level of noise without causing harm to your ear and to your hearing mechanism. Anatomically speaking, when our ear is exposed to a loud noise or loud noises over time, it can cause those crucial hair cells to dislodge from their membranes. It can cause the outer hair cells to completely disintegrate and just not exist anymore. It can cause the blood supply to the cochlea to shift, or it can cause the organ of Corti to detach. Now, TTS stands for a temporary threshold shift. This means that, maybe after a loud concert or hearing a gunshot at close range, your threshold shift for hearing is temporarily lowered. This hearing should return to normal. Now, if it doesn't, you would have PTS, or permanent threshold shift, in which your hearing has been permanently damaged. Some of the symptoms of noise-induced hearing loss can be tinnitus, hyperacusis, which is an oversensitivity to sounds, so perhaps something that would never have sounded very loud to you in the past now hurts your ear when you hear it, as well as a decreased dynamic range. After looking at all of the disorders and impairments of the various parts of the hearing mechanism that can occur, it's important to look at the role of the audiologist and what they are supposed to do to help this situation. So first of all, we have screening. An audiologist screens for these type of problems. They can, either look directly in your ear to be able to see as far as the tympanic membrane. They are responsible for newborn screening, as you can see in the second picture, as well as screening for young children, using toys to help the child relate and give feedback as far as their hearing is concerned. Now, once this screening process is through, a treatment plan needs to be considered. This can include hearing aids, and you can see from this picture there are many different sizes and shapes of hearing aids, and all of those need to be considered as far as a treatment plan is concerned. And then I included a picture of a doctor and a nurse simply because an audiologist may need to refer their patient for surgical treatment, for therapy, perhaps to see a speech-language pathologist. Not all of the treatment can be provided by an audiologist. And importantly, management is also the role of the audiologist. They simply don't provide their patient with a hearing aid and leave it at that. They have to show the patient how to use it. They have to listen to the patient's feedback over time, re-screen for declines in hearing or perhaps improvements in hearing. That treatment plan may need to change over time, and the audiologist is the one who is responsible for making sure that they are consistently building a treatment plan for this patient.